Welcome. I hope you had a great summer, and I appreciate you joining us for today's Knockout Opioid Abuse Day Learning Series webinar, Understanding and Supporting Recovery. So I have a few housekeeping things to just go over with you. Today's webinar is designated for one AMA PRA Category 1 credit, one ANCC contact hour, one ACPE contact hour, one AAPA Category 1 CME credit, and one ADA CERP continuing education credit by the American Academy of CME Inc. And you'll see that information on your screen. Also, for any pharmacist claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has been approved by NJOEMS for one EMT elective CEU credit, and I see that we have a number of EMTs on with us from the chat, so welcome. The Partnership for a Drug-Free New Jersey is approved by the Board of Certification, Inc. to provide continuing education to athletic trainers, ATSs, and this program is eligible for a maximum of one Category A hour of continuing education. PA Planner Dean Barone discloses that he serves on the speakers bureaus of Ethicon and Johnson & Johnson, and all other planners, faculty, and reviewers have no relevant financial relationships to disclose. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc., and is held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I am so pleased to welcome today's expert faculty. We have with us today Dr. Rusty Reeves. Dr. Reeves is Director of Psychiatry at Rutgers University Correctional Health. He's a professor at the Department of Psychiatry with Rutgers, Robert Wood Johnson Medical School, and the Forensic Psychiatry Training Director, also at Rutgers, Robert Wood Johnson Medical School. And we're so pleased, Dr. Reeves, to have you with us today for your unique perspective that is new to this series as we talk about correctional healthcare. And so, Dr. Reeves, welcome, and I'm going to turn the presentation over to you.
Thank you, Angela. I appreciate it, and I appreciate Partnership for a Drug-Free New Jersey inviting me to participate in your series. And I'm hoping that this talk, it's my bread and butter. I'm hoping it's relevant to those who are in the audience. My work is, as you stated, it's principally in corrections. I will touch upon opioid use disorder in the communities, and we will leave time at the end for questions, and hopefully I can address whatever questions may arise. So let's go ahead and get started. Looking forward to it. Next slide, please. Okay, so these are my bona fides, just again so y'all can understand where I'm coming from. I am a faculty at Robert Wood Johnson Medical School, part of Rutgers. That is the campus in New Brunswick and Piscataway. I'm a professor there. I have worked for Rutgers since 1999, basically my whole career. I have been the director of psychiatry for Rutgers University Correctional Healthcare since 2005, when University Correctional Healthcare, UCHC, came into existence. Interestingly, we came into existence through litigation, and this is something I teach my forensic psychiatry fellows, and it's worthy of teaching anybody, is that for good or bad, a lot of improvements in institutional care, including correctional health care, come from litigation. I wish it weren't so, but inmates, a lot of them can't vote. They're not particularly well educated. They don't have advocates for the most part, and they don't have money themselves. And so a lot of improvements are driven by litigation. We came into existence in 2005. There was a litigation, the CF versus Terhune settlement agreement that started in 1999. Initially, the state couldn't satisfy the litigation with its own provision of healthcare. A private company couldn't. And then they took a chance on Rutgers. And in a few years, we did help our client, the Department of Corrections, sunset this litigation. So University Correctional Healthcare is an unusual academic correctional affiliation. There's another one in Texas. That's the other big one, in which we provide the medical and mental health care to New Jersey state prisoners. And that's what I've been doing since 2005. In the wake of that work, I am also the creator and training director of a forensic psychiatry fellowship at Rutgers. This is a one-year fellowship that psychiatrists do after completion of residency. I also do research. That's not my primary job. I'll get to some of what I'm doing, but I do research. I publish in peer-reviewed journals, but I am not foremost a researcher. I am a practitioner, a clinician, and an administrator. I joke that I have no conflict of interest in this presentation. Sadly, I wish I did. I suppose I would be making a lot more money if I had a conflict of interest, but I have none. So I'm not going to make any money on any of the medications that I talk about today. Next. The learning goals here are, we'll discuss the treatment of opioid use disorder and corrections with a focus on the work we do, but also noting the work that's done across the country. Again, our client is the New Jersey Department of Corrections. They run the state prison system. The participants will leave the session informed of and be able to state the consequences of opioid use disorder, the prevalence of opioid use disorder in criminal justice settings, obstacles to treatment of opioid use disorder, and best treatment practices. Next, please. Okay, so I have plenty of time here. I'm going to go over these slides, and I provide a lot of stats in the slides. I might go a bit into some hopefully useful anecdotes. But the consequences of opioid use disorder, I think most of the folks who are on this talk probably are already quite aware of what the primary consequences are. It can be death by overdose, but also slow death by other reasons. So overdose deaths, this is the opioid epidemic that we're talking about. And I give some stats here. The US has perhaps reached the peak of opioid deaths, I hope, and that we had a decline in 2023, a small decline of a few percent, still over 100,000 total overdose deaths. And of those, about 81,000 were deaths due to opioid overdose in 2023. And the great majority of those were from fentanyl, which is a synthetic opioid. It's cheap to make. It's now the main opioid out there that's used illicitly, and it's the source of the great majority of deaths across the country, including in New Jersey. Still, there was a decrease overall in this country for 2023 of overdose deaths compared to 2022. So, that for what it's worth is a good turn. It's still very high. New Jersey has a predicted decline of 3,000 to 2,600 overdose deaths from 323 to 324. And this is mostly, again, due to opioids. I should tell you a little bit about my understanding, my background of some of the original sources of the heroin and other opioids have been around for decades, hundreds of years. They've been used and abused. They're great pain medications. I remember when I was in medical school in Texas at University of Texas Southwestern, which was the main public hospital in Dallas. It's kind of like a Bellevue of New York City. And at the time, that's when these new pharmaceutical opioids were coming on the market. And we were told to use pain as a fifth vital sign. And we were told to prescribe opioid pain medications for anybody who had pain. And we did as we were instructed. In hindsight, the literature was scant, if that was charitable. And that led to some of the opioid epidemic. It was one of the original causes in the past few decades. Iatrogenic. It was indiscriminate prescribing for good intention, but indiscriminate prescribing. And I came to appreciate that as the years went by about being careful about prescribing medications, assuming just because you have good intentions that everything is going to go well. And so I brought that knowledge into the work I'm doing here in the corrections in New Jersey. And I'll get to that in a second. Additional problems, the consequences of opioid use disorder, are a myriad of healthcare problems. Hepatitis C, it's associated with HIV infection, and of course, a whole range of psychosocial problems. Unemployment, problems with relationships, crime itself, thus incarceration. And that's a reality that our clinicians deal with every day working in the Department of Corrections. Next, please. So the prevalence of opioid use disorder in corrections. This is something I came to appreciate intuitively before I learned about this kind of slide. We came into business in 2005 to provide the mental health care, not the substance abuse care. And so still there was that unfortunate schism between mental health care and substance abuse care. And that divide is separated over the years, which I think is a good thing. But still, we were brought in to treat so-called just mental health care. Well, we were doing that for a number of years. And we were doing a good job. And I looked around and still people were having problems in corrections, huge recidivism. And I'm looking around and I'm realizing I knew what was out there in the community. You had methadone, you had buprenorphine, you had naltrexone for both alcohol and opioid use disorder. And I just started checking. I said, they're all substance abusers. All my patients are substance abusers. Of course, that's hyperbole. Hyperbole is fashionable now in some political circumstances, but the average inmate across the country, and including in New Jersey, abuses substances of one sort or another, typically multiple. And poof, this great realization hit me. And I said, this is something that we can address. We weren't contracted to provide it, but it was a standard of care in the community. I said, this is something that we could do to try to improve the care we provide our patients, our inmate patients, to bring us closer in line with what the community does. And frankly, also a good business opportunity in the sense of we could do it without vastly increasing our budget. And I thought it would also be useful to our client, the Department of Corrections. So, and then help our patients. So win-win-win all around. It wasn't until we began this and started out with naltrexone in 2010. Over the when that started, that went well. Actually just started with a guideline before we even prescribed medications before release. I mean, it was that primitive back around 2010. Then we got into prescribing naltrexone, oral naltrexone, which is an opioid antagonist. And then we moved into buprenorphine around 2017, 2018. And then around 2020, 21 into methadone. So it was an evolution. We were the second state in the country to provide all three medications after Rhode Island. And Rhode Island is a state that I tried to emulate. There's a doctor up there, Jody Rich, who educated me about what was going on. And I consider him an exemplar ahead of me who helped move this. And I would say also, I helped raise the sales. I was not the only one here. There are lots of others involved. Even Governor Christie, say what you will about him, he had a soft spot for people with opioid use disorder. And when we needed the money to make this happen in the New Jersey Department of Corrections, it was there, and we had the governor's support and ultimately the commissioner's support. The prevalence of opioid use disorder, it's common among inmates. And you see there a slide, and I give the attribution there. It's people who have increasing amount of opioid use, particularly heroin use. There's common criminal justice system involvement. Illicit opioid use is frequently associated with crime, stealing to support one's habit, other injudicious acts. And so a lot of persons with opioid use disorder pass through corrections each year. Corrections, jails, and prisons are a natural spot to diagnose and treat opioid use disorder because that's where the opioid abusers are. It's the same for hepatitis C, or even for that matter, to a certain small extent, HIV. That these these are places where we can see a lot of people with this disorder, and it makes hopefully substantial improvements in public health. Next. Prevalence, and here's some more stats on the prevalence of opioid use disorder in corrections. So this is from SAMHSA. They reported that about a quarter to a third of persons with a heroin use disorder pass through correctional facilities annually. And about 17% of state inmates and 19% of jail inmates report regularly using opioids. By the way, I've included at the end of my talk the references that I've used, and I would hope you find them useful. I do that to let you know that I'm trying to know what I'm talking about, and I'll let you know when I get into anecdote. But this is all based upon the literature. Okay. In the New Jersey Department of Corrections, I just recently did a summary of our electronic medical record, and approximately a quarter of our inmates who are currently incarcerated have a diagnosis of opioid use disorder. So this is not published. This is just a search I did, and which more or less aligns with other states across the country. So a substantial minority in New Jersey, and for that matter across the country, of inmates have this problem. The relapse rate is high when our patients with opioid use disorder are released. And there was a study by Gordon. Gordon and crew work out of the Friends Institute in Baltimore. They do very good research on opioid use disorder. And I've used some of their articles here in this presentation. So I would encourage the academics among you to search out their work, because I think it's rigorous research and they know what they're doing. They found that 2/3 of released inmates who were not released on methadone tested positive for opioids at 6 months. This is something that I did not appreciate. Again, while I came into business in 2005, we were treating mental health care, that the relapse rate was so high when people, and there are actually other studies that suggest it's even higher, closer to 90% at 6 months. So this was a conservative estimate. People with opioid use disorder is a huge temptation to return to opioid use disorder. It's often referred to as a disease, and it has elements of disease to it. And I don't get hung up on the disease versus habit. I think it has elements of both. It's you ever know, you talk to somebody with opioid use disorder, for that matter, alcoholism or any substance use disorder, it is a habit, but it's a habit that's very hard to break. Nonetheless, at a certain point, because we don't have a medical cure for it, there is going to require, as it were, an act of will to get treatment and to help overcome this addiction. And it's not easy to do, and I've come to appreciate that. That is something that I didn't appreciate when I was initially skeptical of bringing in medications to treat opioid use disorder. I didn't realize that the relapse rate was so high. I thought enforced abstinence in corrections, that time of being sober or relatively sober, would help reduce the relapse rate. There's no evidence that was my misconception. I think it was a misconception of many of my colleagues, general medical physicians and psychiatrists as well. It's just wrong. Another thing that I didn't realize, and this is not in the slides, but the overdose death rate is huge when people get out of jail or prisons. And it actually may be worse because there may be periods of relative sobriety, if not actual sobriety, that lowers your tolerance to opioids. And then you go out there and you go to the same street corner, same dealer, and you use the same amount of opioid you use, or thinking you were using the same amount of opioid you used before. Your body doesn't have the tolerance for it, and you overdose and die. And it happens. And particularly now with fentanyl, which is in, I hear from the patients, it's even in things that aren't reported to be opioids. It's in things that are purported to be Xanax, which is a different class of medication, benzodiazepine. So it's everywhere. So people die when they're leaving from jails and corrections, and ironically, because they may have been relatively abstinent. Part of the problem is that this is another misconception of mine, is that people in prison were free from opioids. And if you've ever worked in a jail or prison, you know that's not true. Opioids get in to prisons, and I have not researched how they get into it, but I do know they get in through various ways. They get in by way of people. People bring it in. And it's also sent in. So loved ones bring it in. Rogue officers bring it in. Civilians bring it in. And there's other substances that are brought in. I won't go too far off on this, but K2, or one of these synthetic cannabinoids, over the past couple of years, which has been a real scourge in New Jersey, are brought in by painting the dissolved medication onto letters from loved ones. And then it's smoked. So the creativity of our inmate patients is endless in getting these substances in. And it's creating fits for the Department of Corrections to interdict it. They're using ultra red lights to flash it if they see the substance painted on letter. They're also copying letters now and giving copies of letters in case there was illicit substances painted on it. It's amazing how things get in to corrections, but they do get in. I would still say, though, it's compared to the street, people are much less intoxicated overall than they would be if they were on the street, for what that's worth. Okay, let's move on to the next slide, please. Okay, so treatment of opioid use disorder in corrections. This gives you an idea about how dropout of treatment is common, and it gives you some comparison with persons with other diseases or disorders. You'll see that the 6-month retention rate for opioid dependence is low compared to those with HIV infection or hypertension or diabetes. Their retention rate isn't so great itself, but nonetheless, relatively, persons with opioid dependence are lower still. And that's important to understand. Engagement in treatment, substance use treatment overall during incarceration is associated with the decrease in substance use post-release. That's not limited to opioids. Structured treatment programs may be a protective factor in relapse prevention post-release. Binswanger has done some interesting work on this, and she is the one that produced the study about the risk of overdose upon release. And post-release transitional therapeutic community treatment improves drug abstinence rates. So this is saying that treatment, in addition to, or not just exclusively due to medications, can be effective for persons with substance use disorders. Next. Okay. So what have we done, UCHC's done differently? Well, again, I said we're the second state to introduce all 3 treatments for opioid use, all FDA-approved treatments for opioid use disorder into corrections. And I've gone around the country and given talks about this, about why it should be done. It's a community standard, first and foremost. And as I said before, the relapse rate is huge and the overdose rate is huge. This is a natural reservoir of patients with opioid use disorder. This is an opportunity. This is not a liberal or a conservative argument. It's more of, I'm a doctor. Where are my patients with opioid disorder? They're right in front of me. Let's treat them. There are 3 FDA-approved medications for opioid use disorder. There's methadone, which is an opioid. It's given orally, typically daily. There's the newer kid on the block, which is buprenorphine. It's also an opioid. It's given sublingually, meaning it's dissolved under the tongue or on the cheek, inside the cheek. And there's both the sublingual form and a long-acting injectable form that is given subcutaneously, which means under the skin. Importantly, again, these are opioids. So they are in the same class as heroin, let's say, or fentanyl. Uh, but their properties are such that they are, if you want to, for those of you who are against medications, it's harm reduction. So you're giving people an opioid, but they can take these medications as substitutes for heroin or fentanyl or other illicit substances. And if they're using them properly and not using additional opioids, they can go about their lives and they can recreate their relationships with their family and friends. They can obtain and maintain jobs, and they can function like they couldn't function when they were using the illicit substances. One of the great things I particularly like about buprenorphine is its pharmacological properties, even better than methadone, in that it has a ceiling effect on its euphoria. You can't just get it high, high, and high to where you're dozing off. It's difficult to do that, and particularly it has a ceiling effect on respiratory depression. So methadone, you can overdose and die. It causes respiratory depression, just like heroin or fentanyl can. Buprenorphine, it's hard to do that. There are some deaths that are reported in the literature from overdose on buprenorphine, typically with other substances like a benzodiazepine, such as Xanax, or even alcohol. But it's hard to overdose on buprenorphine itself. It has that effect where you just can't reduce your respiratory depression even with a large amount, which is a wonderful thing to have in case somebody decides to take too much or inadvertently takes too much. And at the same time, it reduces cravings to use opioids, just like methadone does. And it helps people stay off of the other medication. So I really like buprenorphine. It's also, you can take it home. Methadone, you have to earn the right to take it home after a period of time. And buprenorphine is just much more convenient. The same, imagine if you had to go to a clinic to take your Lipitor because you had high cholesterol, you probably may not stay on that Lipitor very long if you had to go to a clinic every day. Again, there are some people who benefit from the structure of the methadone clinic. Now, don't get me wrong, I'm not, dismissing them, but a lot of people can do fine on buprenorphine. And in fact, in New Jersey, I have the numbers. When they vote with choosing what they want to be on, it's overwhelmingly buprenorphine compared to methadone or naltrexone. Overwhelmingly, over 90%. It's quite clear that that's what our patients prefer. Naltrexone is the third one. That is an opioid antagonist. In other words, it blocks the effects of opioids. So it is not potentially addictive, as are methadone and buprenorphine. On the other hand, that's its weakness. Because it gives you no euphoria, it's questionable about whether it reduces the cravings or not. There is some evidence that it does reduce opioid cravings, but it doesn't. If you talk to folks, and I've run this experiment, I've participated in a retention trial on Vivitrol and Sublocade in our system. It's a study out of NYU. You sign some people to Vivitrol, they take it once or twice, they're not feeling it. They want to go on buprenorphine. It just doesn't do anything for them. I think it is useful for people with a lot to lose, who have may not have as serious an opioid use disorder and are willing to just be totally abstinent, not have any opioid in their system, because it's hard to maintain it. And that's also an injection. It's a big injection. You get it in your buttock, in your gluteal muscle. It requires a lot of commitment. So those are the three medications that we provide in the community. And in a moment here, I'll talk to you about, I tend to be a pessimist about things. And I suppose that's equally as stupid as being an optimist or Pollyannish. But I was one of the authors of this, and we are investigating through a couple studies, one out of NYU and also one out of Rutgers itself, another NIDA-funded study. Steve Crystal is the PI on that, to see what happens to our inmates who leave who have opioid use disorder. So we're providing this, and at the same time, we have to be careful about iatrogenic opioid use disorder. We have to be careful. It's monitored carefully because it is widely diverted in the system. We don't have an easy way of tracking how widely diverted it is, but it is commonly diverted, both by persons with opioid use disorder and people just taking it to have a good time. And we try to balance prescription of this with trying to minimize diversion. Again, getting back to the epidemic that was created by a lot decades ago by indiscriminate prescribing, the difference here in corrections is we're not offering opioids as saying, here, you take this, I recommend this for your pain. If they're coming to us and they're saying, and they're giving evidence of opioid use disorder, first we have to believe them they have an opioid use disorder, and they're asking to be put on medication that if they didn't know already, they're going to be told from our clinicians, this will addict you. This is physiologically addicting. This is what you're getting yourself into. This could be better than the alternative, but at least in the sense of informed consent, if they're trying to play us and they don't really have a severe disorder, well, I'm erring on the side that they're telling us the truth and we're giving them information, so it's informed consent. So that's my trying to keep in mind of what happened decades ago when we were indiscriminately prescribing opioids. Medication for opioid use disorder for released inmates, there's evidence that it increases engagement in treatment, decreases drug use. But this is not even in every study. It's not unanimous that it decreases in drug use in every study. In sort of a hierarchy, it's clear that it gets engagement in treatment. Almost all the studies that look at this shows you get at least initial engagement in treatment when you treat people with medications for opioid use disorder. Less so that it decreases drug use over time, but most of the studies show that. A little bit less so that it reduces crime. See, this is the thing in corrections. We're looking to medicine now for anti-crime pills, anti-violence pills. So you have persons who are violent. Well, what medications can we prescribe for violence? And we do that, but there is no FDA-approved treatment for violence. There is also no FDA-approved medication for crime. So we have to be careful to set expectations clearly that when we're prescribing for opioid use disorder, yes, we're not going to be naive to not think and hope that it will reduce crime, and we will study that. But that's not what these medications were created for. There's a lot more to crime than just treating opioid use disorder. People who commit crimes, there are various reasons for it. Opioid use disorder, substance use disorder is commonly a causal reason, but it's not the only reason. So there needs to be more involved in a person's life, typically, than just taking methadone or buprenorphine. And there is some recent evidence that it reduces death. This is a study, again, out of Rhode Island that showed that there was a substantial reduction in overdose deaths with people who were, when people were treated with medications for opioid use disorder in Rhode Island. And I list that in the references. Next. Treatment for opioid use disorder in corrections. And this is some of the stuff that we're doing. University Behavioral Healthcare, which is our parent organization, created a peer navigator system. There have been peer navigators used to help people with various disorders and diseases in the past, HIV, diabetes, and this is innovative in that it's being used for persons with substance use disorders who are leaving the New Jersey Department of Corrections. They're assigned to a peer, in other words, a person who formerly had a substance use disorder. They're recovered, and they help provide emotional support, psychological support, navigation, literally sometimes driving somebody places, helping them find proper treatment in the community, encouraging them to get to their appointments. And this is created because we found here that before this system was in place, few of our patients actually made their aftercare appointments. The success of IRTS, Intensive Recovery Treatment Support, otherwise known as Peer Navigator. We're studying that in this study that I'm going to mention in a second to see if it's actually making a difference. And preliminary evidence that we have shows it is making a difference in getting people into treatment and to staying into treatment. This is just recently published. I'm one of the co-authors on it. It's associated with the post-release Medicaid enrollment, receipt of medications, and engagement in psychosocial treatment. So far, initial studies on this of our released population show that it is helpful in addition to medication. And this so far, what we show is that both medications and Peer Navigator independently but synergistically help persons with opioid use disorder. And so the two research studies that I'm involved in, one is a NIDA-funded NYU-sponsored. Josh Lee is the PI out of NYU, multi-site randomized retention trial of extended release buprenorphine versus extended release naltrexone. And we're seeing which medications people stay on longer when they're released in the community. And then there's another one out of Rutgers itself, NIDA-funded, that is combining databases, and it's starting with the electronic medical database in the New Jersey Department of Corrections that I've helped organize and get that data to the researchers at Rutgers. And they're combining that with Medicaid treatment databases, Medicaid hospitalization costs, prescription fills, opioid overdose database, death databases, criminal recidivism. This, I think, is going to be huge as it goes down the road in a couple of years because it's naturalistic and it has tens of thousands of subjects in it. And I'm pleased that I've been allowed to participate in this and contribute to it. So I think this is having to show the courage of your convictions. If you're going to introduce this treatment, it's not merely that we're saying we think this is a good thing. We're trying to say, is this making a difference? Next. Obstacles to care. It's hard to find out, to get reliable data from across the country of what state system is doing what. This is a 2018 study. Even at the time, it was inaccurate because they said they had no information on New Jersey. If they'd have called me, Rusty Reeves, I would have told them we were prescribing naltrexone and buprenorphine at the time. But they didn't reach me. I don't know why they got no answer, but this is the kind of stuff when you're trying to do this, you reach the wrong person or they're not particularly having a good day and they don't get back to you. So you can look at that separately. Next. A survey in 2019 found that there was some treatment of medications in most state systems, and 62% were available. 62% of systems had all three, but it's kind of limited. A lot of systems, methadone just for pregnant ladies, not for everybody. Buprenorphine not as commonly prescribed. Most systems still in the country prefer to just use naltrexone, the opioid antagonist, because it's not a drug of abuse. So it's very uneven how it's prescribed across the states. Funding was the most frequently cited barrier. Let's go on to the next slide. That the cost is not so much an issue anymore, at least for sublingual or oral meds. And I give the cost of buprenorphine there, and the costs are when you're going to inject the medication. This is something we face in New Jersey. It's $1,700 a month to prescribe Sublocade, which is the long-acting form of buprenorphine. That's hugely more expensive than the pennies relative for sublingual buprenorphine, and we don't really have good evidence yet that Sublocade is superior to the sublingual form. So as a director of psychiatry, I can't shout and demand that we start that yet widespread. It's just too expensive and hasn't been demonstrated for its clear superiority. I suspect it will be found superior, and there are some studies that are coming out. So I'm looking forward to seeing those. Methadone, huge regulatory requirements. We outsource to a third-party vendor. Makes it easy. They're already licensed, plug and play, as not actually plug and play, but a lot easier than if we have to go through the licensing and maintenance of that licensing. So we partner with New Brunswick Counseling Center to provide methadone. Another obstacle to providing care is it requires secure storage, and the administration of buprenorphine, and in particular in our system, it's a huge custody and nursing monitoring cost. Just the time that's involved to monitor folks. And that's not something we were appreciative of. And that's another reason people drag their feet in this, is because it's a cost of time for staff. Um, methadone is relatively cheap. I would say it's sort of along the lines of buprenorphine. Uh, but only about less than 5% of our opioid patients are on methadone. They're just not interested in it compared to buprenorphine. Next, other obstacles. 10 states do not provide Medicaid expansion. New Jersey does. If you don't have Medicaid expansion and you're released inmate, you likely don't have health insurance, and so you're not going to be able to get the medication. Correctional administrators are reluctant. There is widespread diversion. There's intoxication, which is real and can cause problems. There's security issues of it being gang people pushing up on others and diverting it and gaining control of it in a prison system. And there's even stigma on the part of patients and inmates themselves. And I'm sure you've heard this if you're a clinician. They're about to go and they say, "Oh, doc, I've kicked it this time, and I'm not really sober if I'm on this." I don't argue that they're not really sober. I'll say, well, you're not really dead either if you're taking this medication. And also, you kicked it this time. That's what you said the last time you were here. And I'm not that blunt necessarily with my patients, but you try to use some motivational interviewing to get them to question some of their assumptions about whether they really are free and clear. Next. Okay, so we've got 10 minutes now for questions. Thank you.
Thanks so much, Dr. Reeves. That was a great comprehensive presentation. I just want to mention before we go to questions, and to give you a minute, that you mentioned Dr. Josiah Rich, and he presented for us in this webinar series back in 2023. So I put that link in the chat, and you can also visit the Knockout Day website to watch that, as Dr. Reeves said, some recommendations from Rhode Island. So for those of you who are with us from Rhode Island or other places around the country, I welcome you to watch that. But Dr. Reeves, we'll go straight to this question. There's a lot of different types of healthcare professionals involved in today's webinar. We have nurses and doctors who are on with us. Can you tell me the best way that they can, in your experience, work together?
Work together. You got to be a little
So,
bit clear.
yeah, I'll say, how can these groups act to better support people in recovery, and how can they work better to provide the comprehensive care, that's crucial for people who are in treatment or seeking recovery?
Okay, so if you're a doctor or nurse, you have to, if you're not already, you have to educate yourself about the disorder. You have to recognize that it's real and it's serious and it can be lethal. This is something that I've come to appreciate. So I've educated myself. I've listened to others who know better than I do. I don't have crazy expectations that I'm going to solve the world, but it's a real disorder. And there are medications now that can be useful. I've gotten past you're not really sober. Yes, it's great if you don't need to take the medications. That would be ideal. If you can get past it to where you don't need the medications, that's super. The problem is this long-term studies on opioid use disorder. It's like long-term mental illness. It is chronic and relapsing. People do great when they're on medications. They feel fine. They stop the medications and they get worse. So it's chronic and relapsing. You have to diagnose it when you see it, and you have to start treatment. I know it's often being started in emergency rooms now. So there might be emerging literature on that, and to refer people immediately to treatment if they're willing to get it. I mean, that's the best way to recognize it's real and try to get people into treatment. But I suppose that's kind of a banal answer, but that's the best I have.
No,
I'm
I
not
think
sure.
that's helpful. Sometimes, right, we have to go back to basics when we talk about that. And can you we have some questions from the chat. Can patients be stabilized on both buprenorphine and opioids?
Can they be stabilized on both buprenorphine and opioids? Buprenorphine is an opioid. So I'm not sure exactly how to answer that. I think if you're going into surgery, the anesthesiologist needs to know if you're on an opioid, obviously, or if you're on an antagonist too, because then opioids may not work. And so that's important to know. But as far as I know, I've never seen somebody on both buprenorphine and methadone, for example. I've not seen that combination. Um, I'm
Okay.
going to answer
And
this
then
one. There's one question here that I'm going to answer just right now because I should have said it. Everybody who leaves our system with opioid use disorder, any substance use disorder, or any mental treatment gets an appointment in the community. Not here's a sheet. Good luck. They get an appointment if they're willing to get one. That is something that we do. I want to make sure that that's clear. We're not just sending people out into the void, and the Department of Corrections enrolls them in Medicaid.
and that's an appointment
For opioid use, for treatment for opioid
for
use disorder, a clinic that will continue the prescription, for example.
That's great. Okay, that's important. You talked about the studies on how patients began their addiction, medical prescriptions or self-medication for other mental health disorders. Can you speak to that? What did you find? Was there anything that was brought to your attention as a higher instance?
Well, over the past couple of years, I'm hearing fewer and fewer stories of patients saying I was started on pain pills, but it still happens. I still hear that. And that's for what it's worth for other prescribers, doctors, APNs. Um, be real careful about starting opioids on anybody, even if they don't have a history of addiction. And all the time I heard, I'd never taken opioids before. I broke my arm, my leg. They prescribed me Percocet, and I liked them a lot, and I kept taking them, and I became addicted, and it just increased from there. So anecdotally, I've seen that sort of practice decrease, but we in corrections here are very careful about prescribing any opioid pain meds because we see what it's done to people. And and I watched it happen. I watched it develop while I was in med school. And it's not something I'm proud of. And I'm not necessarily blaming anybody here, but I have a respect for medications and be careful when you prescribe these.
I think that's a really key point and really the theme of why we do this learning series, right? So that people are aware of the risks of prescribed opioids as well as other ways of accessing opioids. But that's a really valid point. You mentioned the studies with NYU and some other groups. Can you speak to when those might be released or available?
Well, the NYU study is still it's finishing up with its follow-ups in the community, about a year-long follow-up in the community. So it'll be over a year before anything really substantial comes out. The reports from Rutgers are trickling out now, but we don't really. I would imagine another year or so before we start seeing results from our Rutgers work. Although, again, we have seen some work that initial stuff is that the peer navigator is associated with getting people into treatment. Again, it's not a controlled trial, though, the Rutgers study. So these people may be already motivated to participate and stay sober.
All right. And then before we go to just your final thoughts, can you speak about how those who are with us today who may not be in the medical field, it could be faith-based or people who are in the prevention and treatment recovery communities, people who are impacted, what role can they have? We have a lot of EMTs who are on with us and other medical trainers or physical trainers. How can they play a role, whether it be in stigma reduction or in helping people identify if someone has an addiction? Any thoughts on that you can share with
Well,
us on that?
EMTs is kind of out of my bailiwick. They might have more to teach me. I suspect if they're not already, I can see more than a year ago learning about prescribing opioids for buprenorphine for people coming into ERs with opioid use disorders. I wouldn't be surprised if it's not already happening in some areas that people are going to be given buprenorphine if they're given Narcan to gets them out of an opioid overdose, to be given buprenorphine right then and there. I wouldn't be surprised if that starts to happen, because it's hard to overdose on buprenorphine itself. But the EMTs, I don't have a whole lot to teach them there. You know, they have it tough, and I'm sure they try to refer people to treatment. And at that moment, the person may not be interested in treatment when they're just recovered off the street. In the New Jersey Department of Corrections, there is a third-party gateway that provides the psychotherapeutic care, essentially the group work for persons with substance use disorders. It's a licensed residential in a certain prison where they provide that, which complements the medications that Rutgers provides. So that is a huge part too. You know, getting back to the disease versus habit, at a certain point of persons with substance use disorders, again, I say, for what it's worth, no matter whether you think we live in a deterministic world or not, it requires, for want of a better word, an act of will, or several acts of will, ongoing acts of will for years and years to reduce use and stay clean, in addition to medications. So there's a lot to be said for social support, consistent engagement in treatment. So I'm not downplaying NA or AA. They've helped lots and lots of people. And I encourage people to engage in that if that's something they find useful.
No, that's so helpful. Before we go to you for your final thought of the day, I just want to mention that information on how to access continuing education credits are available. You'll see the links on the screen in front of you. And Dr. Reeve, we'll go back to you. Again, one last thought for the day.
One last thought, keep your shoes tied. No, one last thought. You know, I have come about my appreciation for substance use disorder kind of during the second part of my career. And I've come to appreciate, how lethal opioid use disorder can be, and some of my misconceptions about forced sobriety, and how it's easier, if you've been sober, you're not going to relapse, and learning how lethal it can be. And in my own studies, I've watched the numbers tick up of people, even though we've provided treatment, a few of them have died. So it's a real problem, and it can be diagnosed, and there are treatments, and we should treat it just like any other medical problem.
All right. Thank you so much. Again, thanks for your time, for being with us, and all the adjustments that you made for your presentation. We appreciated you sharing so openly with all of us today. So thank you again for being part of this learning series.
Thank you.
Yes. And I thank all of our attendees again for being with us. You'll see information on our upcoming webinar. It is on October 3rd. We're so pleased to have Dr. Christopher Jones from SAMHSA, who will be our keynote speaker, Knockout Opioid Abuse Day, looking back and looking ahead. And it's going to give us a great perspective on everything from what's happening in the federal level to where we've been to where we're going. So I hope that you can join us on October 3rd. There's a link in the chat, and you can be a part of Knockout Opioid Abuse Day on October 6th and throughout the month of October. We have resources available. There's digital toolkit and additional information on our website. You can find that information in the chat as well. Dr. Reeves, thank you again. All of our attendees, thank you again, and we will see you hopefully in October. So have a good day, everyone. Be well.